Good afternoon, everyone. The Committee on Department of Health and Human Service will come to order. Will the clerk take the roll?
Senator Santana.
Here.
Senator Cherry.
Here.
Senator Irwin. Here. Senator Kavanaugh. Senator Bayer. Senator Kleinfeld. Senator Outman.
Here.
Senator Huizenga.
Here.
Senator Houck. Senator Tice. Madam Chair, you have 6 members present.
Thank you. Hello, everyone, and thank you all for being here today. The purpose of today's committee hearing is to gain a better understanding of the reckless and deeply troubling federal budget proposals put forth by House Republicans and the impact that it will have on residents across the state and the vital health and human services they depend on. This proposal will have devastating consequences for our state, stripping millions of Michiganders of their health insurance coverage. To put this into perspective, more than 2.6 million people in Michigan, over a quarter of our population, are currently enrolled in traditional Medicaid. Meanwhile, 22% of Michiganders rely on Medicare for their health care. These cuts won't just strip health care coverage for millions of Michiganders. It will also devastate the quality of care for those who remain insured. When funding is slashed, hospital clinics and health care providers are forced to make the impossible choices, cutting services, reducing staff, or closing their doors entirely. Michigan's hospitals receive nearly $7 billion in Medicaid funding annually, accounting for almost 1/5 of their total patient revenue. That funding helps sustain a workforce. Our communities depend on it. Right now, we need a workforce multiplier to grow our economy and build up Michigan families. Instead of a proposal is a workforce divider and threatening jobs, access, and the quality of care. These aren't just made-up scenarios. Real people, our seniors, children, individuals with disabilities, expecting mothers, and working families depend on these programs for access for life-saving treatments, prescription medication, and critical care. Cutting these essential services isn't just irresponsible, it's dangerous and it's cruel, particularly for our rural areas where over 37% of residents rely on Medicaid. If these cuts are finalized, staffing shortages will worsen, wait times will increase while quality of care decreases, and fewer providers will be able to afford to serve our Medicaid patients. This isn't a partisan issue. Across Michigan and the nation, we're hearing from constituents from both sides of the aisle who are deeply concerned about the cuts that will mean for what that means for them as well as their loved ones. Republican and Democrat lawmakers alike have urged Donald Trump, presidential wannabe Elon Musk, and the congressional Republicans to rethink these drastic, unworkable, and senseless funding of cuts. We all support rooting out waste, fraud, and abuse in government programs, but that must be done responsibly, without gutting the safety net of so many Americans that rely on it. We cannot allow reckless budgets to come at the expense of our seniors, our children, and our disabled citizens, and our most vulnerable, our neighbors. The work that we do as elected officials is about protecting the health and dignity of our people, not taking away their vital resources and services for residents rely on every day. To help us truly understand the impact, we are fortunate today to have several caregivers and advocates here with us today. These individuals work every day with the seniors, children, and others who use Medicaid for health insurance coverage and will share firsthand how these cuts will be devastating effects for so many across Michigan. With that said, I will turn it over to Megan Groen, the Senior Deputy Director and the Behavioral and Physical Health and Aging Services Administrator, and Aaron Emerson, Director of Strategic Partnership and Medicaid Administrative Services from the Michigan Department of Health and Human Services to provide their testimony. Thank you, and ladies, please take the podium.
Good afternoon. I'm Megan Groen. Thank you so much for the introduction. I do serve as the State Medicaid Director here in Michigan. Just really want to thank the chairwoman and the committee for having me here today to talk about this important topic. Want to make sure that we have a frame not just of what we're hearing in the news and what's happening on the federal level, but what that truly means for the people of Michigan and what that means in the Michigan Medicaid program. All 50 states and territories have a Medicaid program. They look different in every state, so the impact might be different depending on whom you're talking to, and I want to make sure that this room is all very aware of what that means in the state of Michigan and what that is specifically to our program. Okay, a little bit of background in the Medicaid program. Medicaid is the largest insurance program in the United States. It is a means-tested entitlement program for comprehensive health coverage for eligible populations. So that's low-income children and families, elderly and disabled individuals, pregnant women. What I think is really important for people to see too is the Medicaid income. So this is who is covered, right? And so it is generally a program for low-income individuals, and that's kind of the different programs that we have. The eligibility is a little bit higher for children than it is for children and pregnant women than it is in our Healthy Michigan plan and for traditional Medicaid. That Healthy Michigan plan that you see there, which is 133% of poverty, it does have a 5% income disregard, so you will also see it sometimes referred to as 138% of poverty. That is the expansion population, so that we've had in Michigan since about 2014. So Medicaid is a joint federal state program for these low-income individuals and families. It is run by the states and it is under federal rules. In terms of Medicare, which is also often confused with Medicaid, that's the federal health insurance program for adults 65 and older, and some people under 65 with certain disabilities. Medicaid, not Medicare though, is the payer for long-term care services like nursing homes. Want to talk a little bit about who is in the Medicaid program in the state of Michigan. In the United States, 1 in 5 people is on Medicaid. In the state of Michigan, it is 1 in 4 individuals are on Medicaid. So we are talking about our friends, our neighbors, our family. That is their health insurance. That's how they have well child visits, prenatal care, psychiatric visits, substance use disorder treatment, chemotherapy. That is where 1 in 4 of us are getting that treatment. Our seniors count on Medicare for those long-term care experiences as well. And it's something that, sometimes people don't realize how many children are covered in the program. Of that 2.6 million Michiganders who are covered with Medicaid, 1 million of them are children. 300,000 people with disabilities, 168,000 seniors. And that Medicaid expansion population, so that's folks who had a little bit higher income but still under 138%, that's 725,000 people. Another important thing I think it is to know about the Medicaid program is we pay for almost half the births in the state. And so that's, something that the legislature has been very supportive of, and making sure that we have the funding to make sure that we have a robust program for pregnant women, because 45% of births in Michigan are covered by Medicaid. I wanted to take a moment to share what Medicaid enrollment looks like as a percentage of county population. So if you look at this map, the darker green areas are going to have a higher Medicaid population. It is different as you look throughout the state. What I want to make sure people notice, and that I find people sometimes don't know, is how many people in rural counties in Michigan are covered with Medicaid. In a lot of our rural counties, it's 40% of their population or more. That means in rural areas, more people would be positioned to lose health care if there were dramatic cuts. At the federal level, healthcare providers in these areas would be more likely to close because they would not be getting that revenue. When healthcare providers close because of cuts in Medicaid, they don't just close for Medicaid beneficiaries, they close for everyone in that community. And in many rural communities, your rural hospital is the largest employer in that area. And so that really means, for those hospitals, for those providers, that we're looking at potential job losses. I sat through a number of consultations yesterday with some of our tribes, and they were talking about their tribal health centers. I had one tribe share with me that 69% of their revenue was from Medicaid. And that tribal health center does not just serve tribes, it also serves the whole community, but that's a large employer in that area, and how people access that care. I also wanted to take a moment to talk about who is in Medicaid and then what we spend our money on, right? And so what that looks like. A very small amount of individuals in Medicaid makes up a majority of the cost. These are seniors, individuals with disabilities. That's only 15% of the people on Medicaid, but they represent 45% of the cost, right? These are mandatory things that we do in the Medicaid program, like cover nursing home care for our seniors who are both low income and covered by Medicaid and Medicare. And so that's something that, I want to make sure people understand what that looks like from an expenditure perspective. 80% of the services that we have in the Michigan Medicaid program, 80% of that spending is on mandatory services, and those are federally required services. Of the remaining 20% of that spending, the largest share in services you might not think of as optional, or I wouldn't think of as an optional, like pharmacy and home and community-based services for individuals with disabilities. So of that remaining 20% of the non-mandatory, right? Pharmacy and home and community-based services for individuals with disabilities make up 80% of that. And so we're really looking at, some really important pieces here. And, just to help people understand, again, where those expenditures are. Just something I thought that might be helpful for everyone is to know kind of the average monthly cost. For the average monthly cost for a child in Medicaid is $361.47. The average monthly cost for a senior and individuals with disabilities is $2,110.96. And part of that is the services that people are seeking, right? A well-child visit costs around $100 in the Michigan Medicaid program in terms of our expenditures. An individual in a nursing home costs the Medicaid program about $6,200 a month. And so these are, again, we talk about who is in the program and then what we're spending the money on. We're also a major payer in the healthcare system, and I think this is something, I know we have some others that are coming up to discuss the importance of Medicaid in their businesses as well. Just wanted to make sure that we really covered that nationally Medicaid accounts for about 1/5 of all healthcare spending, and over half of that spending, again, on long-term care. So we're the largest payer of mental health services, long-term care, births, and really play a critical role for these hospitals, behavioral health providers, long-term care providers. And that's a little bit, that pie chart is going to show you a little bit of the background of, again, where our expenditures go and who we pay. Wanted to talk a little bit about the cost effectiveness of Medicaid and what we've done specifically in the state of Michigan. So this is really looking at Michigan data right here as we compare to commercial insurance, and as we kind of look at that national healthcare landscape. We've done a lot to contain costs in the Michigan Medicaid program, just to really be able to kind of keep that budgetary piece down. So cost in healthcare has gone up, and you can kind of see on this chart how that has really risen in the health insurance premiums on the marketplace, kind of with that national health expenditure piece. We've really been able to control costs in Medicaid. Some of our spending kind of per member that we have in Medicaid is much lower compared to both the commercial market, Medicare, the marketplace, but also according to some recent data that we looked at from the Kaiser Family Foundation, Michigan's in the kind of the lower 9 states for spending per member. That's just over $5,000 and far less than our neighboring states in Indiana, Ohio that look closer to $8,000 per member. So I wanted to talk a little bit about how Michigan Medicaid is financed, which is probably not the most exciting thing about Medicaid, but something I think is very important as appropriators to know and understand. So Michigan has a much higher federal match rate than its neighboring states. So when you hear things about that federal match rate being reduced, that means it's going to impact Michigan more than it impacts our neighboring states in the Midwest and across the country. So those reductions that you hear about might hit home harder in our communities and in your districts than they would if you were, say, in Ohio or Indiana. Some wealthier states like Massachusetts and places like that, their match rate is closer to 50-50. Michigan's match rate is 65%. So every dollar you're putting in, you're getting $2 back, which is giving us $3 to spend on those beneficiaries that we were just talking about. Some of those wealthier states, it's more of a 1-to-1. So we are, again, bringing a lot more federal match into the state of Michigan. We also get a lot of our dollars for administration, such as IT costs are matched at 90%. For simple impact of Michigan, if that 90% were to go away, just for IT projects alone, it would be $115 million in state funds needed to simply maintain current operations. This isn't new things, and we got lots of new ideas, and I'd love to share those with you, but today we're kind of here to talk about maintaining current operations, and that'd be $115 million just to maintain that if that administrative match rate were to be brought down. Wanted to talk a little bit about Michigan's Medicaid budget. It's large, it most certainly is, and certainly something that we want to discuss with you all. It is about 71% federal, and a large portion beyond that federal comes from provider taxes, which are also kind of feeding into that federal piece. Provider tax is a way for the Medicaid program to increase some of the reimbursement that is given to our providers. So in terms of how this works, we have provider taxes that, then we tend to pay on the lower side in terms of our rates. There's lots of people here today that will tell you that we pay less than Medicare, we pay less than commercial insurance, and it's hard for them to cover a large proportion of Medicaid beneficiaries at the rates we pay without a little boost. And so what provider taxes are able to do is give our hospitals, give ambulances, give nursing homes an additional funding stream for if you serve a lot of Medicaid beneficiaries, you do get a little bit of compensation for that because those rates are so low. So when we're really looking at, kind of how that structure is and what the state share is in terms of general fund, that is about $4.3 billion, which is a lot of money. It's about 15% of the program. When we start talking about what the federal cuts that we're hearing that are proposed in budget reconciliation are, I want you to remember that $4.3 billion number because some of these cuts go pretty far into that. So we would have to have that general fund plus whatever people are looking for the state to start picking up in addition to, what the federal government used to cover. I wanted to talk talk a little bit about how Medicaid helps hospitals. With Michigan Medicaid covering a quarter of the state's population, kind of that uninsured rate has continued to lower as we have expanded Medicaid back in 2014. We are one of the lowest uninsured in the country right now at about 4.4%. That was about 8% before that nationally. Since the launch of Medicaid expansion, hospital uncompensated care has fallen dramatically, decreasing by more than 50%. That's care for which the hospitals did not receive payment prior to Medicaid being able to be accepted for these individuals. The percentage of hospitalized patients without insurance dropped by 69% when we expanded Medicaid. And so we're really looking at Michigan hospitals receiving nearly $7 billion in Medicaid funding annually. That's about 1/5 of the net patient revenue for hospitals around the state. Wanted to talk a moment about rural communities. Rural residents rely on Medicaid to provide much-needed insurance coverage. When we're looking around, we saw that map. We looked at a lot of our counties being at over 40% Medicaid. If we just take a look at small town and rural Michiganders, over 37% of them are covered by Medicaid. Across the country, we've seen a lot of rural hospital closures. That's not to say that we haven't in Michigan, because we have certainly seen that here too. But places that did not expand Medicaid saw more rural hospital closures. And that's something that, we're very worried about from an access, from an economic, and from a jobs perspective, right? And when a hospital closes in that community, everyone is left without access to care, not just those in Medicaid. Just wanted to talk briefly about how Medicaid helps the economy. We have actually seen quite a bit of economic activity since we've expanded Medicaid. The Michigan Health and Hospital Association is here today and can probably talk much more about it than I can, but the estimates are about $77 billion a year in the economic impact. Healthcare is the largest industry in our state, and that, when we've expanded Medicaid and really looked at that, the University of Michigan study found that just that expansion population alone created more than 30,000 jobs a year. These jobs boosted personal spending power. They result in tax revenue back to the state of around $150 million. We've actually seen in the population, in the Medicaid population, that employment has grown as in that population as individuals have gotten healthier and had that Medicaid access. So in the Healthy Michigan population, we see a greater employment in that population as well as people have gotten healthier. I wanted to talk for just a moment about Medicaid and kids. Medicaid is one of the areas that has probably been the most studied. And some of that is because we have so much data and people have been looking at this for so many decades. And we really have been able to, and I should say we, not me personally, but certainly from a lot of folks who have evaluated the waivers, evaluated the programs, been able to track individuals for years. And what does happen when you give a child Medicaid as opposed to not having insurance at a very young age? What happens to them? We now know that when those individuals are adults, they had positive health outcomes. They're healthier. This is something I think a lot of us would expect, right? You give people health insurance and they're healthier. We can also track those individuals and say that they have a higher educational attainment, they have higher wages in adulthood, and they increase future tax revenue from those increased earnings. And that's just by giving a child Medicaid. We can really look at the economic mobility outcomes for giving low-income pregnant women on Medicaid. We really look at the economic mobility outcomes of those children in adulthood, and they have higher wages, higher educational attainment, higher tax revenue. There was a Congressional Budget Office at the federal level estimated that long-term fiscal impacts of the Medicaid spending on children offset half or more of the program's initial cost. I just think that's an important thing to remember as we're hearing about potential cuts, what this program has done for our country and the individuals it serves over time. And with that, I want to talk a little bit about what the potential Medicaid changes we have heard. I do not know exactly what Congress will do, but what I do want to do is make sure that individuals on this committee know when they hear things in the news, what that would mean in the state of Michigan. So one thing that we have heard to get to that budget reconciliation number is reducing the 90% federal match for Medicaid expansion. You heard me talk quite a bit about Medicaid expansion. If you were to bring that 90% match, we get back down to 65%, the state would lose $1.1 billion annually. Absent an investment to cover that, 30% of Michigan's Medicaid population would lose their health care coverage. We talked a little bit about provider taxes, and yes, the state of Michigan does use provider taxes. We are not an outlier in that by any means. As of fiscal year 24, Alaska is the only state that doesn't have a provider tax structure. You know, Michigan, again, uses that for nursing homes, hospitals, and ambulances. You know, 44 states have hospital taxes, 45 states have nursing home taxes. This is not something that's unique to Michigan, but we do leverage them to bring in that additional revenue for this state. You know, most states do that. Michigan does leverage it. We have done a lot to keep our general fund cost low for the state. If you go back to the 90s, we used to spend about 45% general fund in the Medicaid program. It has kind of ranged between, I think it was 12.5% over COVID when we kind of had an enhanced federal revenue stream coming in there, but has ranged from that 12.5% to around 30% for the last few decades here. You know, and that's something today we're at that 15%. So if we were to see the federal government decide to cut away some of these funding streams, again, you know, that's, you know, we used to have a much larger general fund share in the program, but that was, you know, quite a long time ago in the 90s. So we have heard about limiting those provider taxes, and that would be, of course, something that would be pretty detrimental to the hospitals and others in the room, as well as the state, because we use those to fund the Medicaid program. We have heard a lot about work requirements at the federal level. I think in the Healthy Michigan population, I believe it was 64% of people are working. We have a little experience with work requirements in the states here. It cost us about $30 million previously when we were looking at implementing those, and that's an increase, you know, to those administrative costs. You know, we did have some concerns about coverage losses. I believe it was, you know, between around 100,000 individuals that we thought coverage would be terminated at that time. And we did believe that some of those individuals were certainly working, but had not gone through that process to verify their employment with the state of Michigan. We have heard some talk about ending enhanced federal match for administrative pieces. I think the big takeaway was the $115 million for IT projects just to maintain where we're at. That's just a huge fiscal impact to the state. In terms of when you hear about per capita caps or block grants, that type of structure, nobody has given us details on what exactly that looks like, so I can't give you an exact number of what it is, but kind of what we look like from that national landscape and some modeled to date projects is that Michigan could see a reduction in federal funding of $16 billion between fiscal year 2025 and 2034. We did in these slides, I know these are pretty dense in terms of kind of what all these definitions are and these federal terms and things like that in terms of the how those federal cuts would come. And so we did in the supplementary materials that we provided the committee include kind of some of those, you know, what is a provider tax in Michigan? What do we have here? If there's any additional questions on that, always feel free to reach out to the Medicaid team. We'd be happy to answer them.
Thank you so much. Members, are there any questions? Yes, Senator Altman.
Thank you for your presentation. You know, as we talk about potential cuts, I mean, it's right now it's all speculation, right? But there probably isn't much argument that in any government bureaucracy, there's always a certain level of fraud and abuse, as well as a certain level of inefficiencies that could be eliminated. And Congress has signaled that they want to look at this problem to see if we can find any savings for the American taxpayer, or at the very least, to help right-size the ship when it comes to our federal deficit and our national debt. And I'm guessing that even you are in favor of that, of looking for any types of savings that we could achieve, right?
Absolutely. We do a lot in the Michigan Medicaid program today, and I would be happy to kind of work with the committee on things that we could increase or kind of some program integrity pieces we could add. I do want to share a couple of the things that we do today, though, that maybe we could build off of. So we do have a comprehensive set of safeguards kind of to prevent that fraud, waste, and abuse. Again, completely agree with you. We're committed to ensuring the integrity of the program and continuously improving those efforts kind of to save those taxpayer funds. A couple of our key program integrity measures in Michigan is efficient eligibility and renewal. So we want to make sure that the people who are in the Medicaid program are under the federal rules, the people who are supposed to be in the Medicaid program, right? So we use advanced data matching to streamline and verify that eligibility determinations, and that reduces some of the manual processes that can lead to more of those prone to errors, we'll just say. Third-party liability, or TPL, as you'll sometimes hear it referred to, is something, the Medicaid program is the payer of last resort. We recover funds from other sources